some of the great people that taught me, some of the people that went to the program with me. I mean, this is basically what we are the product of. Some of them are not with us any longer, but it's for us a very, very proud heritage. And it's not really about ages or techniques or fashion or fads, because some of these concepts are really timeless, okay? And real diagnosis, real treatment planning, real sequence of therapy skills are timeless. You may incorporate any tools such as implantology, of course, which is the subject of this meeting, digital tools, of course, which are extremely helpful and may change substantially how we may deliver care to our patients. But once again, the basic, and I know it's boring in a meeting like this, basic diagnosis and treatment planning skills are a timeless skill. So today, I'm going to be talking about, I've been asked to talk about, modern day paraprosthesis. Is there any value to it? Or is anything still applicable? What are the challenges we have, particularly in the area of implant dentistry? And the profession has changed in many ways. Obviously now there's a tremendous amount of emphasis in aesthetics. Dental implants are ubiquitous. Digital dentistry is all over the place. And now, of course, people are, again, starting to recognize the importance of interdisciplinary approaches. So I want to start in looking at this by taking revisiting a case that we did actually in doing a residency training. And you may remember this case, Henry. He used to sing in Atlantic City. And you can see this is the typical peripros case of the era. And again, during our residency days, take a look at the challenges. How would you manage a case like this today? All on 4, all on 6, that's the easy answer. Okay? There could be other complicating factors related to patient management, related to patient expectations. So take a look at the defects, the papilla. I mean, we debate about 0.5 or 1 millimeter of papilla. Are these numbers relevant here? Gingival margin discrepancies, tooth size discrepancies. How about the occlusion? Secondary occlusal trauma. People are not talking about this anymore. Migration of teeth, occlusal plane disharmonies, a host of factors to take into account. In terms of biologic and biomechanical risks, we have obviously the consequences of having to do with a reduced periodontium. And this is where crown-to-roof ratio comes into consideration. Caries susceptibility, of course, with this patient, we have endodontically treated teeth that many times leads to compromised tooth structure. And in this particular case, lack of posterior support. Now look at the time. This is 1987. Implants were extremely limited in the US. Okay, they're not as ubiquitous as we have them now. Certainly not an option when we're going to the program. So we're going to use very rudimentary orthodontics, and we're going to basically try to align the occlusion, harmonize it as best as possible, level occlusal planes. Carlo, this is what we used to do back in the day with the metal bands. Quick grooving for a partial. This is the BOPT precursor. But you see that when the case is completed, there have been a number of compromises. There's a full arch prosthesis with cantilevers. There are some survival risk issues to consider. There's a reduced periodontium. There's caries potential. Compromised tooth structure, of course, many of which are related to endodontically treated teeth. We have third molar cantilevers and also a full arch splinter prosthesis. So immediately, immediately we look at situations having to do with the crown-to-roof ratio, the pronounced susceptibility, the diminished support, the reduced periodontium. I'm worried about that. But in fact, there's literature, classic literature, going all the way back to Niemann and Lindy in 1979 that show that the risk factors were mainly technical and biomechanical. And that has been also published more recently in systematic reviews, where basically the risk factor for periodontitis was assessed to be only about 0.5%, and for caries, 2.6%. So the problems with these larger reconstructions are more biomechanical in nature. And if we take a look at the literature again, this is what we find as biomechanical risk factors. And let's take a look at the highlighted text. Cantilever FPDs with non-vital abutments, significantly greater failure rates. Long bridges, 5 or more units, meaning that these full arch splints carry also a higher survival risk. FPDs with non-vital abutments and those of a longer span, once again. Post-core abutments led to significantly more failure. So if now we take a look at the type of cases that where implant dentistry modifies these risk factors, we see that if you place more implants, for example, there's no issue with reduced periodontium. That is resolved. Titanium doesn't suffer from caries. So that's an issue that's not a problem anymore. Inadequate tooth structure, well, that's resolved with including having more implant abutments. Non-vital abutments, that goes away as well, as post on course do also. Cantilevers, we don't need that. We place posterior implants. Long spans, we don't have to splint full arches. We can now place more implants and segment the reconstruction into posterior and anterior sections, for example, therefore reducing the risk. Well, let's take a look now at some of the risk factors that are not modified by implant therapy. And these are obviously having to do with gingival alveolar defects, which is the same type of case that we do in that we see in periodontal prosthesis. So what if there are other moderating factors? For example, high smile lines. So now you have the presence of gingival defects, alveolar defects in high smile lines. How should we address that? And I think that this is the challenge for periodontal prosthesis cases into the future. One challenge that the Atlanta team has been tackling for 20 years or so. Okay, so there are a number of tools that are available to us as a result of our heritage of interdisciplinary therapy that can be applied to this. So since this is a meeting, an implant meeting, let's take a look now at the potential aesthetic risks of implant therapy. In terms of definitions, what we'd like to see is an implant-supported restoration that emerges from the tissue naturally as a patient's own tooth does, or as a tooth-supported restoration does. So to achieve this, obviously, the peri-implant soft tissues are key. And therefore, the well-established pink aesthetic score, published now over 10 years ago, and you see that all these parameters are related, of course, to the quality, to architecture of the soft tissue. So in terms of aesthetic predictability, how is it that we are going to deal with compromised sites? Do implants solve this situation? Do pink restorative materials solve the situation as well? Can regenerative techniques compensate for these defects? Can we predictably restore papilla? Can we predictably restore appropriate peri-implant soft tissue architecture using traditional GBR techniques? So let's take a look at different implant scenarios. Are there some that are more conducive to aesthetic results than others? And this has been published by Belster a number of years ago. And of all these specific scenarios that he identified in the literature at the time, the only one that could be treated aesthetically on a predictable basis was a single tooth implant. And we all know why. Because what happens is, in a site without tissue deficiencies, the attachment apparatus of the adjacent tooth helps you maintain the level of the peri-implant soft tissues. So if we're going to deal with a single tooth restoration, there are a couple scenarios. One is that the patient comes into your office with the tooth missing, in which case you have no choice but to actually embark on the traditional delayed approach, right? So this is an approach where you will require regeneration and more than likely several procedures. If, on the other hand, the patient presents with the tooth still in place, you may then be able to utilize an immediate placement and provisional approach, which is one that emphasizes preservation rather than regeneration. We're all doing this procedure now. It's very popular because of the fact that it's conservative, it's efficient, it decreases treatment duration, there's less expense and morbidity, it has similar success rates than the traditional technique, and also provides predictable aesthetic results. So you guys don't have to take notes. I basically just, this is all on Dental XP, so you can actually review the whole protocol there. But basically we have flapless surgery. And you know, when Steve was talking yesterday about adjacent implants and that type of thing. With Felipe and I, we had this commentary. All that literature with adjacent implants, with or without platform switching, is with flaps. It's flap-based surgery. And the issue is what happens if you raise a flap. And I think we need to be more cognizant about that. So you're going to see an insistence here in flapless type of approaches if we're going to ensure consistent aesthetics. So a traumatic extraction, followed then by, as an aside, I don't know about you, you probably are in the same situation as I am, but I'm typically extracting teeth that have compromised tooth structure. So the purchase is limited. The leverage is limited. So many times I find that whether in anterior posterior areas, this is a very useful situation for me. So for the sake of efficiency, I start drilling with a high-speed burr, but then I actually use the implant burrs. And then in the process, as you hollow them out, you sometimes get enough purchase so you can actually luxate the remaining root fragment. Then we like to utilize a tapered implant. We feel that that's a more conducive microgeometry to basically achieve the primary stability that we're looking for. Platform switching helps as well. There are a number of insertion torque numbers that have been published. We like to work with the area of 40 or 45 centimeter. And then, of course, we need to select a system that's going to be to provide us with the ability of maintaining crest of bone as well. And regardless of what kind of manufacturer you're dealing with, I mean, there's any number of systematic reviews that show that if you have a platform shifting, mismatched platform or what have you, or platform switching, you will basically just be able to maintain more crest of bone. Okay, and then we talk about lingual placement. We talk about insertion torque. I prefer to use a minimum 2 millimeter gap, and I graft it using a xenograft material. We published this technique a few years ago. This was in actually, we presented it first in 2010 at ISPRD. And we basically just saw that there is no changes up to 6 months. We could not go any longer because of limitations imposed on us by the university's IRB. And we thought that the stability of the buccal plate following this protocol after 6 months was due to the fact that the flapless technique limited the resorption of the external aspect of the buccal plate, while the lingual implant placement would prevent the resorption of the internal aspect of the buccal plate because there's no impinging on that buccal plate at all. So then we have to go through a process of provisionalizing, and this has been very well shown. There's substantial differences in mid-facial margin levels with or without a provisional, and then of course contour comes into play. And that's a separate part of the discussion. We published about contour a few years back, and I owe that presentation at XP as well. It's coming. But then again, to just summarize this, we take a look at situations where a critical contour is utilized to basically achieve the ideal gingival architecture. So there's more of an aesthetic rationale, and because of this, it is non-negotiable, particularly doing a single tooth. And then you have also a subcritical contour that also comes into play. And this subcritical contour may have both a biologic and aesthetic rationale in terms of thickening the tissues and basically just serving as to enhance preservation of crest of bone, for example. So we handle the occlusion also to ameliorate or mitigate the risk. I like to open the bite. And we see that there's also overall agreement from this consensus literature review as well. This is from the ITA group, where you can see that a lot of the same concept you're utilizing or we're advocating are listed in some of the key bullet points. For us particularly is the fact that for this to be predictable, we work with intact socket walls. So this protocol is on intact sites. So everything that you'll hear from me today in terms of immediates, I always work with intact or ideal sites. So in PeriPlus, what we've had is a number of tools to deal with situations related to treating the periodontally compromised cases. which one of these tools can we utilize today to develop compromised sites. A classical example has been, when seeing a case like this, to utilize one of the many tools in our armamentarium, also one of the most popular, one advocated also by the Atlanta team, but actually perhaps will agree that Jeff Ingber is the person that we should give credit for this, and that is forced eruption. So when done properly, what will happen is that you will get a coronal migration of the attachment apparatus that may be sufficient for us in this particular case to reestablish then the papilla levels, as you see here. And that would allow us then to basically just develop a site that was compromised into basically an ideal implant site. In this particular case, we decided to just preserve or keep the lateral, and you can see why. You can see the clinical signs there, or parameters. But if we had chosen to actually extract that lateral, you would have been placing a single implant in an ideal site, exactly the type of situation that's the most predictable aesthetically. These are the results and the radiographic appearance. So this technique can be utilized also to develop sites that are multiple. And again, we are not as worthy in thick biotypes and in situations where we do flapless, immediate type of cases when we deal with adjacent implants. And this is one such example. This is how the contours are managed, and then the final restorations. Okay, so this can be parlayed into more. There's a next level, and that will involve, for example, cases where distraction may be a good alternative. And I'm just going to show you one of them because it's really not we have a limited amount of time. But this is basically just a single block osteotomy. And what we're going to do is just basic, well, we're parlaying our forced eruption experience into this, into another tool that helps us to develop a site that was deficient because of the position of that tool which was ankylosed. So we graft for volume as well during the procedure. And now this case turns into a fairly simple case, just another immediate implant case. We're decoronating this too because it's ankylosed. I realized that we could use a partial extraction protocol here. This is done several years ago before the publication of Socket Shield. Okay. And this is how the case is resolved. And you can see now the radiographic appearance before, after the distraction, and after the implant placement. So this is predictable. We can do it fairly well. I'm going to now show you a case that has caused us to incorporate and develop perhaps new tools to include in the armamentarium paraprosthesis. Let's take a look at this case. So she's in her early 20s, and she is a college student now in medical school. And this is a result of an attempt to place an implant in a congenital edentulous lateral site. And the implant failed, the bone graft failed. There are two subsequent attempts to bone graft, they failed as well. When the surgeon proposed another bone graft, the patient said, well, we're not going to do this. And so did the parents. And then, the whole round of second and third consults went around, our area, and eventually I ended up seeing this patient. So is this a case where you do surgery? How is it that you can actually achieve how can you achieve a good result here? I show you the smile line already. Let's take a look at the size of the defect here. So there's a poor prognosis already on these two teeth adjacent to the space. High risk case now, there's legal action going on. I'm not involved because I will not get involved, but there's legal action. So what do I do in terms of treatment? Just punt, send it to the other guy? Or does a light kind of turn on in your brain, drawing back to your old days at the clinic thinking, perhaps I can do something for you? And that is going to be, in this case, a choice of these three. Vertical augmentation, that's not in my skill set. And I doubt that, look, anything's possible, but this is a really tough case to do surgically. Okay, you will almost ensure failure. Distraction, teeth are present. So I'm going to use the tool that I know best, which is force eruption, to actually get a result. And that result is going to get the vertical component restored. So, there are nuances about the orthodontics. Okay, but here you have it. And now this is a post-orthodontic splint. These teeth could not be prepared. If you touch them with a high-speed burr, you could extract them. Okay? The central was basically erupted beyond its apex, and you'll see it on the X-ray. So this is bonding, composite built in situ. So this has to remain now for 3 months during a stabilization period. And you can see here where basically the root tip of the central is basically completely in soft tissue. So this stabilizes, it matures, right? We still have the cleft. We have now adequate vertical alveolar height. These teeth have a poor prognosis. What do? She needs implants. We have no horizontal volume. Would you flap this case? You'd be crazy. The central will go immediately. Okay, so the goal is horizontal volume and preservation of soft tissue. How do I accomplish both? Let's go into the literature. How many times has it happened to you? Look at the literature. The rates are supposed to be very low, single digits in most publications. But you know what? In our program, we have a surgical seminar. I would say that we have a competent faculty and competent residents, certainly around the average. And we see it's more than a single digit. As a matter of fact, it's more than 37%. So this is a very common occurrence. That you'll get bone, yeah, the surgeon says, sure, you'll get bone, you place your implant. What if the soft tissue defect is on the anterior side and the patient has a high smile line? What then? And if you look through the literature, you see that there's a theme that resonates. We have advanced reconstructive surgery, especially GBR, increasing risk for complications and compromised aesthetics. Less favorable pink aesthetic outcomes in augmented sites. Flap surgery contributes to better aesthetic outcomes. Limit opening papilla. Okay? Be careful with a thin scallop biotype, which is this case. So, this is something I developed I wasn't looking to develop something. What am I going to come up with? This is a response to basically a clinical challenge. Okay? And this is what it stands for. Subperiosteal minimally invasive aesthetic retraumatization technique. So it's one new tool that we're adding to the bag of tools of paraprosthesis. So this is minimally invasive surgery. Started with a remote incision. I'll tell you where it comes from, where the development came from, what is the provenance of the whole thing, or the whole concept. This is basically this has been published, so you can read it in IJPRD, and more recently in Compendium. And you basically gain laparoscopic access to the site, okay, without damaging the periosteum. And again, this is just Coronatio Compendium. As a matter of fact, this whole case is there. They asked me to publish it in detail. It's still in temps. She's in med school. I can't get access to her. So this is what we do. This is a 2-incision case. So basically what happens here is, we agreed also, you see many ortho patients that end up with the Hissens's or thin buccal plates, right? It's a young patient. She already has some initiating recession areas. So we just agreed to include or expand the scope of the graft. And this is what we could do with 2 incisions. Let's take a look at the sites now. So this is canine side lateral, which is going to be a pontic, and then the central, and subsequent implant placement. So now this can be an immediate implant placement. So we have now modified these sites so that they're ideal implant sites with the predictability that accompanies that. This whole procedure. Does it look ugly the day off? Of course, because remember, that splint has been there for 3 months. Okay. More than 3 months. So this is the final appearance. And this is now the patient, still on her temporary. I took the final impressions, but again, she's in med school. She's in some kind of surgical rotation now, and I can't see her as often. And this is basically the treatment she had. Forced eruption, the smart bone graft, immediate implants are provisional. I may do a free gingival graft because I need to release the lip. because her smile, as a result of the degree of eruption, okay, her smile it's a little bit uneven. So what is the provenance of this? Well, I mean, I read this years ago, and it always piqued my interest. And this is Massimo Simeon, PDGF with the vertical blocks, the vertical augmentation with the blocks. So he used a block, I'm not using a block, but it's the same material. And what is he finding of the three groups? The PDGF work with no membrane. You may replace the growth factor, but this is a growth factor mediated regeneration where using the membrane actually worsened the result. He repeated the same study now with a horse-derived block, an equine block. Got the same result. When you don't use the membrane, you get a better result. So these are some of the conclusions. What do you need for this to work? This is with the blocks. On eventful soft tissue healing, blocks infused with the growth factor and no membrane. This is the direct predecessor of the SMART technique. And this is basically Camelo Nevins and co-workers study. And this is, again, look at this, 2009. This is a number of tunneling soft tissue approaches. And this is the closest, and this is actually the provenance of what we're doing. And you see the three groups, of which the BIOS group did the best. So these are the results. FDBA did not consistently provide bone quality and volume required for osseointegration. BIOS group achieved the most consistent results. BIOS collagen resulted in unpredictable bone regeneration. I'm not sure collagen is the answer. So what are some of the initial cases that forced me to think this way? This is one of them. So what would you do? This guy presents to us, okay? He goes around. All the other clinicians propose extracting that tooth. And he says to me, by the way, I'm getting married in 8 months. Look at the smile line. You're going to take out that tooth. There's an implant next to it. How many procedures? What do you think is going to happen to those papilla? Do you think 1 millimeter would matter? So extracting this tooth is exactly what you should not do. So we're talking about interdisciplinary, and a lot of times we don't include the endodontist. So I called the endodontist, I said, listen to me, get the fistula away. But the bone said, don't worry about it, you control the fistula, I'll take care of the rest. So he did it. That was the first step. Second step is resolution of the regenerated buccal plate. These are early cases. What you see here, all of them are early cases. Things are substantially different now. I use the membrane here because I was concerned also about a potential residual fistula, maybe at a level that I could not detect clinically. So, step number 3, immediate implant placement and professionalization. So you see, this now becomes a basically routine procedure. Now, the problem is, let's take a look at this x-ray. You see the shape of the bone? You see how funny it is? And you can actually see the prominence here at the, more apically on the soft tissue. And that's a result of the fact that you cannot control the dispersion of the granules when you have the membrane. It goes around, it goes under. And what I found also is that this portion, I don't know if there's a pointer here or not, the superior portion close to the apex of the implant is excess. That excess proceeded to mineralize. It's okay, I'll handle it. Okay, here. That excess proceeded to mineralize right here, further confirming the results from Simeon's study. So it turns out we don't need the membrane, they're right. But again, this is growth factor mediated regeneration. So now we're looking at, we've been working on this for about 4 or 5 years. The cases in this publication, which was submitted in June of 2016, were all treated with the protocol I'm showing you today. Because, of course, there's a period of development, trial and error, screw-ups, this, that, the other, revisions and what have you. So this is what we showed. This is what we published. There's histologic data as well from a human biopsy. It is clear to see in the data that you have the granules. So this is an oriented dissection for you, occlusal aspect. This is where the smart graft is, okay? And this is the area where that you're going to see magnified. You can see the granules, and you can see the formation of new bone around the granules. Another area. I don't know where this one is from, but you can see it clearly. So let's take a look at bone augmentation, because we presented 5 different applications, but I mean bone augmentation is what's reported most frequently in the literature, and actually one dimension, because I measured in 3 points, but the statistics became very confusing. I think for the reader, the data became confusing. So this is not including Urban's most recent publication. Take a look at this. 6 more, I did this number twice, because I was concerned it was so high. 6.47 of horizontal. These are the applications. So I'll show you now some of these cases. And the issue is, do you really, I mean, where are we going? What's the future of our field? Bigger flaps, more bone grafts, more tenting screws, more meshes, more procedures. I mean, are we going the right direction here? So congenitally missing teeth, she, a pretty girl, take a look at this. This bothers her. This is smart bone graft. Take a look at the changes in soft tissue. This was a 1 incision case right here. You can't do it with off-the-shelf instruments. I know because I tried. I have over 100 prototypes. Okay, I need to figure out what to throw out and everything at this point, because I mean, my assistants are going crazy with it. So, but take a look here. And take a look at even the effect it's having on the adjacent tissues. Could it be that I drop some bone here and here? It's possible, because I'm trying to get it through a tunnel. So this is not a lateral pouch or a lateral graft. I mean, this is a remote incision that provides a laparoscopic access. There's no scope, but it's a laparoscopic access to the site. And the greatest application of this is when you can actually go flapless. To me, it's a slam dunk. And it's great also because, provided you have enough keratinized gingiva. But it's great because it also, as so long as the graft is physically or mechanically able to hold the implant, you still have the period of osseointegration for graft maturation. So I love to do it this way. This is the other side. And these are the x-rays. And, you know, again, then provisionalization. This is the day of the provisionals. She had a flipper. I just basically jumped the flipper. She travels, so I don't get to see her often. And this is 2 months post-op. I think I have, I'm not sure I have her final impression. Again, she doesn't live in the area. She travels. So let's take a look at another case. I have this also under horizontal ridge augmentation. Ortho, okay, very prominent roots after the ortho. Non-buccal plates, here, an implant and graft failure already occur. So this is funny because, I mean, the patient comes to me and says, you know what, why are you here? Well, obviously, take a look at the problem. I went to the other guy, an oral surgeon. No disrespect to the oral surgeon, right? I mean, just a guy in our area. And he says he wants to take me to the hospital, take a chunk of my hip, screw it onto my jaw under general anesthesia. And that didn't sit too well with me. I said, what can you do? I said, I think you need a soft tissue graft. And then I did do this bone graft. Of course, yeah, milligrams, it take me 45 minutes. Take a look. Now, these are early. I can shape these better now because I have the right instrumentation and the techniques a little bit honed in. These are early. You'll see it's restored already. Her husband is some kind of CIA or FBI guy that moved to Virginia or, you know, what do you call it? The deepest state or what, yeah. So we agreed, there were financial concerns, so this was going to be a 1 incision case also. So I tried to cover some of the root surfaces, expose root surfaces as much as I could. Well, here, hip graft versus smart procedure. That the implant had to be placed labially, yes, because I release over the crest, but not because I want bone here, because the problem is that periosteum here releases very, very quickly. Then I'm concerned about the grafting material going to the lingual. Another case. This is now lateral augmentation prior to the immediate implant placement. This is a great application, grafting of exposed implant surfaces. 12-year-old bridge and already retreatment. As bad as it looks, this is already a retreatment. Buried implant here. She comes in here. She has fistulas that come up. I never saw it, but she was referred from Massachusetts because of this. What can you do? Well, I said, what do you have to lose? Because the traditional approach involved removing everything and starting from scratch versus this. I have a 2-year post-op on her. This is 2 years, no symptoms. Moved back to Massachusetts. Well, she did move back. I mean, I see her for, She was unhappy because Pennsylvania voted for Trump, and she couldn't stand living anywhere, so she moved. Okay. Bone grafting of exposed implant surfaces. This is a posterior side, more technique sensitive, but this is a more recent case. So you see the contours better controlled. Vertical augmentation, unpublished. Okay? I did not include this because I didn't have enough data, enough cases. I am collecting the data for a case series here. And this is not your easiest case. I mean, I never get the easy cases right off the bat. And this is already a failed case. Some implants were removed, grafting attempts were done, a lot of scar tissue. And the reason why this works biologically is because there's a rationale having to do with wound stability and space maintenance. That's classical GBR. Okay, and again, there's enough information on growth factor-mediated regeneration. And again, the fact that the periosteum is the source of the progenitor cells, which is the reason why it works without a membrane. But again, it's mediated, it's growth factor mediated. For the patient, there are a number of benefits. This is part of the study. Having to do with morbidity, discomfort. Some sites will get more swelling. Lower posterior segments, long ones will get more swelling. For the clinician, it's obvious as well. More predictability, fewer complications, more efficient. Solution for complex cases, no hip grafts. I use no membranes, no tenting screws. Okay, perfect. So conclusions. In the aesthetic zone, preservation is definitely more predictable than regeneration. And these conclusions are a little long, so you can, okay. Well, they're not that short. Immediate implant placement and provisionalization in ideal sites is the current gold standard for predictable aesthetics. So therefore, interdisciplinary techniques should be utilized to develop compromised sites into ideal implant sites. Finally, the smart minimally invasive bone grafting method provides predictable outcomes with decreased morbidity and complications than traditional GBR surgery. It is a disruptive technology with the potential to profoundly impact the future of regeneration. Thank you for your attention. Thank my friends at XP again.